All right, so thanks everyone for coming this morning. I appreciate it. Today's review is going to be on CRRT. I think it's going to be a really nice review. This is going to be a nice balance of the overview of some of the physics and physiology of how CRRT works, and also some of the practical aspects of how we set up CRRT. We'll talk some about how we dose it, and so you'll understand on how things work on the MD side as well. So I think this will be good. Let's get going. Before I get going, I want to thank Baxter for supplying the slides, in particular Joe Orbana for helping me with these slides. Makes it a whole lot easier. All right, so the first topic will be the basic principles of CRRT. So our objectives here is we're going to define renal replacement therapy, CRRT, and the associated modalities. We're going to identify some clinical indications for administering CRRT, including an overview of patient selection. We'll have one good patient presentation here. We'll identify patient access considerations, and so where we put our lines and the Frenches that we use, etc. Explain some of the anatomy and functioning of the hemofilter. I always like that because when we talk about the specifics of that, and it's broken down really nicely, then you understand the basis of how it works, and so it makes problem solving a lot easier at the bedside. And then explain the basic principles of solute transport mechanisms. Hopefully by the end of this, if you are still not clear, if you're not clear now about what's dialysis and what's convection and things like that, it'll be really clear by the time we're done. So, all right, so first, what is renal replacement therapy? So, before we talk about continuous renal replacement therapy, we're going to talk first about, just briefly mention intermittent renal replacement therapy. So this is defined as something that is less than 24 hours. And so probably we're all familiar with intermittent hemodialysis, something that takes place usually along the guidelines of something like 3 to 6 hours or so. And then there's SLED, so sustained low efficiency daily dialysis. Maybe think of it something as double the time of conventional hemodialysis. In some places that don't have the ability in the ICU to do CRRT, when you have your unstable patients, people might consider doing SLED instead. Since it's longer, it might be less volume shifting for patients. They might be able to handle it better. But really, for us, this is going to be about continuous renal replacement therapy. Again, it's defined as something that's greater than 24 hours. And there are different types of continuous renal replacement therapy. There's SCUF, there's CVVHF, CVVH, there's CVVHD, and I'll mention those, but overwhelmingly what we use is CVVHDF. And when we get to this, I'll explain the difference between the two and why. So again, CRRT describes any renal replacement therapy that's intended to be applied for 24 hours per day in an ICU setting. And it's, as I mentioned with those different modalities there, it's a variety of blood purification techniques, which may differ significantly according to the mechanism of solute transport. We'll talk about that. The type of membrane that we use, the presence or absence of dialysate solution, and the type of vascular access. And this is a nice little overview of some of the things that I just mentioned. And so I'll highlight just a few things here. Go back here. Is the duration of intermittent hemodialysis about 3 to 6 hours? In general, SLED's about double that, 6 to 12. And then CRRT is when we have continuous treatment for 24 hours. And then blood flow rates. Well, if this would make sense to you here that since we're only giving treatment in intermittent hemodialysis for a short period of time, 3 to 6 hours, there's a lot to accomplish. And in order to accomplish all of that, we run blood flow rates much higher. So 400, very common, 450 mLs per minute. And then for the other therapies that are longer, you have the luxury of having a lower blood flow rate. Here lists 150 to 200 for CRRT. Very commonly, we use 250 as well. And then when we get to it, we'll talk about how CRRT is unique. When we talked about that last one, CVVHDF, here for the fluid used in intermittent hemodialysis, we have dialysate only, but then when we get to CRRT, for some of the modules, we can add we have dialysis, and we add what's called convection. And we'll talk about what convection is. So it's an additional modality that's used in addition to the dialysis. And then here you see fluid rates. I'm not going to go into this now. And I guess maybe a little bit on the nursing end, because you do encounter this with the bags. It's interesting that intermittent hemodialysis and SLED is non-sterile dialysate, and then CRRT is sterile dialysate and replacement. All right, so let's talk about fluid movement, distribution, movement, and mechanisms. So the average adult is 40 to 60% water. And this is why when we ask for daily weights and we're looking at fluid retention, why the daily weights are so important, because let's just say approximately 50% of that is going to be water. So it gives us a real indication. I have a little 15-month-old at home right now, and it's interesting that newborns are like 80% water. So it's pretty interesting. So when we look at where the fluid is located in the body, we break this up into an intracellular compartment inside the cells and then outside the cells. And so here we can see inside the cell, this is our intracellular fluid compartment. And then when we talk about outside the cell, we have two basic compartments. We have interstitial fluid, and then we have the blood. So fluids constantly shift between the body compartments to transport nutrients, waste, and other materials. So they pass through the cell and capillary walls that act as a semi-permeable membrane. And water passes freely, as do some but not all solutes. So here I'll pause for a second and just simply say here that here's our intracellular compartment, here's our extracellular compartment, and here is our semi-permeable membrane. So this is how nature set it up to where you have a membrane within the body where things goes across. All CRRT is going to be when we talk about the filter is just replacing that semi-permeable membrane that we naturally have, which is that cell membrane with a filter outside. Same mechanism. So let's talk about mechanisms of fluid and solute movement. So factors influencing water movement is osmosis, and this is passive transport, and then hydrostatic pressure gradients. So this is also passive transport. So hydrostatic pressure is just simply if you have a higher pressure on one side, that higher pressure will push it over to the other side. And then factors influencing movement of solutes is simple diffusion. We could have facilitated diffusion, and we have various other mechanisms which are active. So for this, so simple diffusion would be simply that we have, say, sodium on one side, that's a high concentration, and sodium on another side that's lower, and the sodium will naturally go from one side to another. There are some times when solutes maybe can't go across so easily, and they might go through pores, so protein pores, and that could be maybe considered some type of a facilitated diffusion, especially if it doesn't involve energy. And then sometimes when we talk about potassium or sodium, when we want to intentionally have these concentration gradients, we have active transport to where we're using energy to intentionally create a gradient across the cell. So that's an example of all three of these types of transport mechanisms. All right, so CRRT, let's talk about decisions to go on, and we'll start getting into the modalities here. All right, so why choose, why CRRT? CRRT really is how the kidney works, right? The kidney works 24 hours a day, 7 days a week, 365 days a year. And that's exactly what we're trying to set up and mimic when we put people on CRRT. Hemodialysis is something that we just try to do in a short period of time. And these people are outside the ICU, they're home, and we try to develop that to where people can have like a normal lifestyle, to where they only have to go as infrequently as possible so that they can continue to live their life. So patients with the following diagnosis may be candidates for CRRT: fluid overload, and I'll present a slide that perhaps maybe CRRT is better at fluid removal than intermittent hemodialysis, largely because you're doing it for a longer period of time. Individuals with acute renal failure, we'll go over what that looks like and what the definitions of acute renal failure are based on maybe something rifle criteria, etc. Life-threatening electrolyte imbalances, we think of maybe hyperkalemia, major burns with compromised renal function, and then drug overdose. There could be some instances where people overdose on drugs, maybe unintentionally or not, that we can use CRRT to clear some of those drugs. So compared with the intermittent hemodialysis and SLED, CRRT is for gradual solute removal that approaches homeostasis of normal kidney function. As a continuous therapy, CRRT more closely mimics the normal kidney function, as we mentioned. In general, CRRT is indicated in any patient who meets criteria for hemodialysis therapy but cannot tolerate intermittent hemodialysis due to hemodynamic instability. So we commonly think of patients who are mechanically ventilated, maybe or not, but definitely people who are on pressors, who won't be able to withstand. And that just makes sense because since it's running over a shorter period of time, 3 to 6 hours, you need to have a tremendous amount of activity, and people might not be able to manage that activity in terms of their blood pressure. So when we talk about renal failure, it's important to mention the KDIGO criteria, KDIGO opinions, and how they relate to acute kidney injury. So in 2012, the Kidney Disease Improving Global Outcomes work group, that stands for the KDIGO there, released a set of opinions intended to provide healthcare providers with acute kidney information. Opinions were based on systemic reviews of relevant trials, and they gave strength of consensus opinions indicated as level 1, 2, or not graded. And then typically, as we do in medicine, they rated the quality of the supporting evidence as A, B, C, or D based upon what we have. So broadly speaking, if you have something like large meta-analysis trials that you put together, that's probably going to be a grade A evidence. And then maybe things like case reports and case studies are going to be level B. So as mentioned, we use a rifle criteria for the diagnosis of acute kidney injury. And this is nice because this puts numbers to it. And it's important to actually go through this because some people that you might not think are having acute kidney injury based upon they're still having urine output or otherwise might actually have acute kidney injury. And this is how we'll define it here. So rifle stands for risk, injury, failure, loss, and end-stage renal disease. So risk here is an increase in creatinine greater than 50%, or GFR decreases by 25%. So this is important, and this is why we try to get a baseline idea of what someone's creatinine is. It's important to use this in context with 50%. So what do I mean by this? You could have a 50-kilogram female come in with very little muscle mass. And because she has very little muscle mass, her creatinine is normally low, right? It's maybe like 0.4 or something like that, right? And then all of a sudden, she develops hypotension overnight or something like that. And maybe she bumps up to, I'm even going to say 0.8, so she doubles. So she more than 50% goes up. It would be a common misunderstanding for most people to be like, oh, the creatinine's still within normal limits. It's only 0.8. But that patient is developing acute kidney injury or inacute kidney injury right there. So that's why it's important to go through this. So that's risk. Injury in that particular example is just 100% increase in that creatinine, or GFR decreases by 50%. And then failure would be increasing creatinine by 200%, or GFR decreases by 75%. Over here on this side, we just use urine output instead of the glomerular filtration rate and the creatinine. So risk is urine output less than the 0.5 mLs per kilo per hour. So that's what we all look at for greater than 6 hours. And then injury is urine output less than 0.5 mLs per kilo per hour for a longer period of time, 12 hours. And then failure is urine output less than 0.3 mLs per kilo per hour for 24 hours, or anuria for a 12-hour period. So then loss is the persistent acute kidney injury, complete loss of renal function for greater than 4 weeks. And then end stage is when you go past that 4 weeks, you're in end stage disease. It's interesting here that loss is defined here as greater than 4 weeks. You've probably seen it. If you haven't, it's common for people to lose their kidney function for a long period of time, and then eventually they recover over the course of weeks. And so we don't, kind of quote unquote write them off as an end stage renal disease patient until quite some time. So what about the correction of fluid overload? I had mentioned when we can compare CRRT compared to intermittent hemodialysis. And so here's a particular study where we looked at fluid overload with AKI. It was independently associated with mortality. I think this is something that's finally becoming much more recognized, right? Too much fluid is an independent factor for mortality in people. And all too often, patients with sepsis would present and they get pumped with a whole lot of fluid, and it seems like a reflex. They're still hypotensive, they get more fluid. The hypotensive, they get more fluid. And people maybe they didn't have objective measures to kind of look at their volume status or otherwise, but that reflex now we recognize likely contributes to mortality. Our current understanding here, say in sepsis, which is the common area that we use CRRT, is there's this nice little saying, I'm not sure where I got it from, but it's in sepsis, you need the swell to get well, and then you need the pee to be free. And so for the first 3 days of sepsis, it's okay to be fluid positive. It's actually a beneficial thing. But once you go past that 3-day mark, if you're still volume overloaded, that's when the mortality starts to kick in. And so here we're showing that when you have your intermittent hemodialysis, it's harder to get fluid off individuals as an effective mechanism because you only have a shorter period of time. And with CRRT, it's a much better modality to get fluid off. And so here, the Pickard study group says that CRRT may be a better option for fluid removal than intermittent hemodialysis. All right, so let's talk about AKI patient conditions and what we might use it in, the hemodynamically unstable patient, drug overdose, etc. So we'll start with our first clinical case study here. So this is an 82-year-old female, comes in with pneumonia and sepsis. ICU length of stay has been 3 days. And I think 3 days is an important number because that's that time when we have to start thinking about fluid, right? If they're going to remain positive after 3 days or so, we think that there's harm. So the patient's previously fit and well with no comorbidities. Their creatinine is 1.1. Their BUN is elevated, 67. So normal is going to be around 10 or so. Potassium is a bit high, 5.9. White blood cell count is elevated, consistent with their sepsis. Their intake over the last 48 hours was 1.5 liters. Their output in the last 48 hours was only about 1.3 liters. They're on mechanical ventilation. They have a MAP of 59, and they're on both norepinephrine and dopamine. Urine output is 0.4 mLs per kilo per hour with Lasix, so that's less than that 0.5 that we mentioned. And that's the introduction there, and we'll come back to that patient and then the modalities, et cetera, and where they fall into rifle criteria, et cetera. So let's talk about access considerations for a second here. So what do we need for access considerations? Well, we want 11 French or larger in adults. So this is important. And actually, I'll pause here for a minute. Probably one of the biggest problems with CRRT is not running CRRT. CRRT is very easy. When you hook it up and you get things going, it runs well. And we might not be having good outcomes because when you look at how long someone is actually on CRRT, sometimes you have access problems, the filters clogging, this, that, and the other. And when you look, the patient might have only had something like 6 hours of treatment in a 24-hour period of time because you were constantly changing the filter or otherwise. And probably the most important aspect of having CRRT run effectively for that period of time is, again, nothing to do to the machine, it's with the access. If you have good access, things will work better. And so larger is better. And so much so, that's why some critical care doctors like myself are starting to put in from the get-go tunnel dialysis lines. Tunnel dialysis lines tend to be bigger, and we tend to know which patients we think are going to be on CRRT for a longer period of time anyway. So instead of putting a temporary catheter in, we put the larger French in. So this way you can run that faster blood flow, right? You can get that 250 mLs going, and that'll be much less likely for that filter to clog or to stall or things like that. So large size, important, and we'll also talk about, like where it should go in terms of it should be straight. So adequate length, optimal placement. Number one circuit management issue really is the catheter. There's no doubt about it. And it just mentions here to refer to and follow hospital-specific protocols for guidelines. So let's talk about where we're going to put these, guys and where. So preferences for catheter insertion. Let's talk about the first choice right here, right internal jugular vein. So why the right internal jugular vein? Well, because it's a straight shot right down to the heart. And if you put in a nice large catheter that's straight, it's not going to kink, it'll probably work best. So first site to put it in, right internal jugular vein. And then length here, 12 to 15. Here we commonly have the 16 centimeter length catheters. That's where we put it in, right IJ. So what about a second choice? So second choice would be femoral. So it's interesting. So why do we choose the femoral as a possible second site? Well, again, it's a little bit straighter coming up. And if you're going to put the femoral one in, then we want a longer length catheter. So here it recommends 19 to 24 centimeters. All right, so we all know of the patient that, we have a whole plethora of reasons why we can't put stuff up here, maybe thrombosis or otherwise, or they have multiple lines in. We don't want to put a groin site in for who knows what reasons, right? A lot of reasons why. Maybe they have a huge pannus and otherwise, and you can't access. Third choice would be the left internal jugular vein. And so here, it's important that you recognize that you want that longer length because you have to actually traverse from here and go across and get into that downward turn here, down towards the heart for it to be straight, to have, very good access. Ideally, what we would want in terms of where we put these is when we put our tunnel dialysis lines, we intentionally put it into the right atrium. And when we put it into the right atrium, that's intentional because then we have blood flow from the superior vena cava and the IVC. And so getting it down lower is really better. If you get it into the right atrium, that's fine. You might think that's too far when you look at it on a chest x-ray, but it's done intentionally if we can get it there. And then last here that's recommended, the subclavian vein. For a preference on the dominant side, I would say the preference is really overwhelmingly the left side. Because when you look at putting these in, on the left side, it more naturally traverses across the body and goes down a little better. Subclavian access sites work fine. Probably the major reason why we don't like to put them in this particular patient population is that these individuals, if they're going on CRRT, have a risk to go on permanent hemodialysis. And if they're going to go on permanent hemodialysis, they will need a fistula put in their arm. And part of the problem with the subclavian access is that when we take it out, you have a high incidence of subclavian stenosis, where the patient might then have to have another procedure, which is not the end of the world, another procedure where they first have to have like some type of balloon dilation of that stenosis, and then they can put in the fistula. So not the end of the world, but ideally you want to prevent the patient from having another procedure if possible. So let's see, catheter dysfunction may result from mechanical problems, so kinking, catheter malposition, patient positioning or leakage, or thrombotic complications, thrombosis, fibrin sheet formation, etc. So probably something that gets hammered on us, right, is going to be urinary tract infections with their catheters and central line infections. So important just to mention that though we hammer on mechanical complications, CLAPSIs are also possible with any central line, including the dialysis lines. And so just mentioned here. All right, so let's talk about the hemofilter here. So what's the filter, right? The filter is a blood filtering device mainly used to support the excretory functions of the kidneys. And so really, this filter is just trying to take the same place as what the kidney is. And there's a nice little video that's going to come up and kind of how it works. So let's actually start, over here on this side, right? So here, normally in the body, what we have is we have our afferent arteriole coming in. It loops. You have a filtration mechanism right here in the glomerulus. And then you have what really would be the effluent coming down into the proximal collecting duct and then the distal the distal tubules and the collecting ducts coming down here. So really what we're trying to mimic is the same thing with the filter that normally happens in normal anatomy here. So here on this side over here, we have blood, and then here we have dialysate, and here we have our membrane, and it would traverse here. Again, no different than the glomerulus. The same basic setup is what this is trying to accomplish here. Here, blood's coming in, just as it would come in here. Blood's coming out, just as it comes out here. And then we'll talk about how the dialysis runs in a counter fashion and why it does in reference to blood flow in just a second. All right, so let's talk a little more about kidney function and acute kidney injury here. This is that video that I was mentioning here. I'm gonna let it play. We're gonna look at electrolytes, waste, maybe other molecules such as maybe cytokines. And then what happens when these go into the kidney? They get filtered out, and then they go into that collecting duct right here. So here, just an up close shows you the normal waste removal here of what we're trying to accomplish. And then maybe what happens here in acute kidney injury, say ATN, you just have a decreased ability for the kidney to be able to perform these functions. The kidney is just like any other organ, right? I'll go into that in a second. So here we have the hemofilter, and the hemofilter now is trying to act as our kidney and have the same mechanism. So it's that filter. And here you have your effluent out, which is no different than what we're just simply peeing out, right? That's basically the pee that we would make with our normal innate kidneys. So, you know, in acute kidney injury, actually, I think it comes up right here. You know, the kidney is amazing. The kidney is able to have normal pressure regulated. It normally likes to have a pressure of about 65 millimeters of mercury. And it can maintain that over like a very large blood pressure range. But in acute kidney injury, maybe you had severe hypotension, blood flow didn't go to the kidney, and now the kidney becomes compromised. Kidney becomes compromised, part of the tubules collapse, they die, and then you can't have blood flow to the area. And or even if you maybe had blood flow to the area, you might lose that normal regulatory mechanisms where it can control that pressure going into the kidney at 65. And so that's why we normally say in a sepsis situation, we like the blood pressure to maintain at 65 or greater, because if the kidney loses their normal autoregulatory mechanism, we're trying to create that in the body so it has normal pressure that it's normally used to. All right, so basics of some solute transport here. So we'll talk about ultrafiltration, which is super simple, right? It's just really fluid transport. We'll talk about diffusion, hemodialysis. We'll talk about convection and some modes of CRRT. And we'll talk about absorption just very briefly. All right, so ultrafiltration. So what is ultrafiltration? So it's the movement of fluid through a semi-permeable membrane driven by a pressure gradient across the membrane. So I think a simple concept. I don't really think it requires much more explanation. So here we're simply seeing blood coming in, blood coming out. It's under pressure here, and it simply has some of the water come out here through the effluent. All right, so what about absorption? So quite literally, just think of absorb, right? So absorption is the molecular adherence to the surface of the interior membrane here. So here, when we say this is the blood side and over here is the effluent side, when something goes across, it could adhere to the membrane. And this is what happens over the course of any filter life, right? Which is why we look at transmembrane pressure. So the longer that the filter is in existence, it could absorb some of these molecules. Then the diffusion becomes more difficult because it's a thicker membrane because you absorb some of these things. The transmembrane pressure goes higher, and as you're watching that transmembrane pressure go higher, you know that eventually the filter is gonna fail. This is one reason why the filter fails over time. So how about diffusion? So when we think of diffusion, we think of hemodialysis. So diffusion is the movement of solutes only from an area of higher concentration to an area of lower concentration. And so the dialysis pump is pushing a prescribed physiologic solution around the membrane in a counter current direction to bathe the capillary fibers. And down here, the effluent pump is removing dialysate from the effluent compartment. So let's make this real, right? So this is here, blood coming in. So let's say the blood's coming in and we're doing this because someone has hyperkalemia. So they're coming in with hyperkalemia, they have a K of 6.7. We obviously want to get that down. So here the blood's coming in at a K of 6.7 and coming up. What we're doing is we're having our dialysis solution coming in and running this way down. And maybe we're going to choose maybe a 4K bath. So meaning that the potassium is at a level of 4, maybe a 2, maybe a 0. But the idea is a concentration that's lower than the 6.7 that we're dealing with. So then what happens is that the blood, since it has the higher potassium of 6.7, will have the potassium go into the dialysate, go into the effluent, and then come out. That's how it works. So simple diffusion. All right, so here is to reiterate what I just mentioned here. So here's the blood coming by, and maybe here's our dialysate solution here. And we can see that if we had a potassium of 6.8 and we used a 4K bath, then the potassium would naturally go in that direction across and equilibrate, so we get rid of it. If we had a calcium of 2.7 in the blood, and then we had dialysate of 2.5, again, it would equilibrate and go across. But in addition to thinking about things that go from a higher to lower, so going outside the body, we also might need to replace some things. And so bicarbonate is an important one, right? People very commonly have metabolic acidosis for a lot of reasons when they're septic. And so we can have a higher concentration of bicarbonate in the dialysate to have that come into the blood as it goes by. Sodium's usually kept in homeostasis, one direction or the other, 0 and 40. And here magnesium in renal failure patients is usually elevated, so it's usually higher in the bloodstream and it goes to a lower concentration outside. All right, so I thought this was nice. This is a really simple example, right, that we all can relate to. So a tea bag, right? So the tea bag simply has solute in there. Within the tea bag, the membrane is the bag itself. And then the solvent is the water, the hot water. And so solute removal depends upon, solvent removal by diffusion depends on concentration gradients between the blood and dialysate flow rate, molecular size, diffusion clears small molecules, and then permeability of the membrane. And so probably all of these things, the one that I'll highlight, which is why it's bolded, is small molecules. When you think of dialysis, you think of the ability to have small molecules diffuse across. You have difficulties and it's not possible for larger molecules, and that'll be a bridge into convection. All right, so convection, solvent drag, so hemofiltration. So what are we looking at here? We're looking at blood coming in and then blood coming out. And so when we look at blood coming in, what we often do is we add something to the blood, pre-replacement solution. So I'll go through this once and then I'll go back it again. I'll add some more details. And then as the blood comes out here, we look at replacement fluid post. So what is convection? So it's the forced movement of solutes with fluid. The fluid will drag the solutes. Here I'm going to make this like a little more, think of dialysis, right, as we had that sodium just simply go across. So now we have larger molecules, and somehow we need a mechanism to have those larger molecules go across. And so we think of having pores in the membrane, and the pores, so literally, open structures that allow for larger molecules to go through. Well, when you have those larger molecules go through, then water will go with them. And so that's why we say here that it is the solvent drag, or it's the forced removal of solutes with fluid. The larger molecules come with fluid. Whereas in dialysate, you can just simply have the sodium go, right? So here it's fluid. So that's why when we're looking at pre-replacement, say when I set up my CRRT, I use the majority of my replacement fluid pre-filter and only maybe about 200 mLs post. So what I'm doing intentionally is since I know that convection will have fluid go with those larger molecules, you dilute the blood. So you give it the extra volume. So it has the extra volume coming into the filter. So therefore, when that volume is going to go with the larger molecules and you lose that volume, it's less of a big deal for the patient, because that's why you diluted the solution to begin with. It also makes the filter last longer because it's less of a thick solution going through, So you had less of that, absorption type of characteristics. And then post-replacement, the reason why we have post-replacement is again because since we're having a large amount of fluid go with those larger molecules across, we still want to give a little bit post to make sure that the patient remains whatever volume status that we're trying to accomplish here, even or a little bit negative, etc. So here the effluent pump, so that gradient that comes across down the filter, pulls fluid with the solutes from the blood side of the filter through the semipermeable membrane to the non-blood or effluent side. No, post-replacement is fluid and electrolytes as well. Yeah. So solute removal by convection depends on the molecular size. So again, dialysis and diffusion, we're thinking small molecules. Convection, we're thinking larger molecules. High membrane permeability. Think of like pores in the membranes to be able to have those large molecules come through. You can have degradation of the filter membrane that can decrease performance over time. And then replacement fluid flow rate, pressure gradient going across. And so coffee is the example here. So in general, convection will allow molecules up to a 50 kilodalton size. So 50,000 kilodalton size. So if things are less than that size, then they can go across those pores. And so here in this particular example, what we're showing is that urea, creatinine, and glucose are much lower than that pore size. Here's the pore size here, so they can go across the membrane. So then let's show something that's a little bit bigger, maybe some vitamin B12. It's bigger, right? Here listed as 1,355 Dalton, so it can go across that 50,000 kilodalton size. What about bigger? Beta-2 microglobulin, so that's 11.8 kilodaltons. It can go across the membrane because it's smaller than that size. Cytokines. So cytokines, proteins, 30,000 Daltons, they can go across. It's an interesting area that we're constantly researching more, the use of CRRT in sepsis. Sometimes the cytokine response is what gives us ARDS, et cetera. And some critical care doctors talk about using CRRT to clear cytokines. In Europe, we talk about blood purification or things of that nature. And so it's ongoing, and I'm a little excited about it because it could help maybe improve survival for sepsis patients. But now we start getting to the bigger molecules, right? Albumin. So now albumin is bigger than that 50 kilodalton size. It simply cannot pass through that pore. So it stops there. And then your really big things like your immunoglobulins can't go through. So you get the idea that it's contingent upon that pore size of 50 kilodaltons. All right, so I kind of went over this already, but all of medicine is about repetition, so we'll just go over it one more time. So here, pre-filter replacement. So delivered to the circuit access bloodline before the hemofilter. So what's the concept here? We're going to dilute the blood, so decrease hemoglobin. The replacement fluid volume will be removed by the effluent pump. So since we know that in convection, the fluid's going to go with solids across the pores, we give that extra fluid ahead of time so it can go across. And then post-filter is delivered to the circuit return bloodline after the hemofilter. Blood will be concentrated because you just lost all that extra fluid. So here you'll dilute it when you get that post-replacement fluid. And the post-filter replacement solution will deliver replacement solution to replace the removed volume and replenish lost electrolytes. Here what we use is we almost always use the same pre-filter solution as we do the post-filter solution. All right, so let's talk about the different modes of CRRT therapy. So we'll start here with SCUF. So SCUF is just in reference to fluid. So it's slow continuous ultrafiltration. And remember, ultrafiltration was that targeting fluid only. So primary goal is going to be remove patient fluid. Then we have CVVH. And so this is continuous veno-venous hemofiltration. So this is basically like continuous dialysis. And so we're targeting those, I'm sorry. I should have went up here. I went out my own order. So I cancel what I just said right there. Go up to this corner here. I should have went clockwise. So CVVHD. So this is continuous venous hemodialysis. So this is the small molecules that are going across. It's basically continuous hemodialysis. Here we come down to using convection. So we can just use convection alone without dialysis. So continuous venous hemofiltration. So here the primary goal is to remove small, medium, and large molecules. Or what we can do, which I mean, I'd probably say use 95% of the time, is to put the two together, which is the CVVHDF. So this is the continuous venous hemofiltration. So here we're going to get the benefits of both dialysis and convection all in one. And as a practical tip, remember that we usually set the machine up for CVHDF because if you wanted to maybe use one of the other modalities midstream, if you set it up for the full thing, then you can always backtrack out. If you set it up for one of the limited modalities, then you need to change the whole thing. So CVHDF overwhelmingly used. All right. Here is a breakdown of what we just mentioned here. So in SCUF, we're looking just to remove fluid, right? So no dialysis, no convection, so therefore no replacement fluid. What's removed is fluid alone. Here, CVVH, so we're looking at convection. So dialysis, no. Replacement fluid, it's convection, so yes. What are we removing? We're removing fluid and solutes. So CVVHD, so continuous dialysis, we do use dialysate because this is dialysis. It's not convection, so no replacement fluid. And we're removing fluid and some solutes. Here the key is, again, small solutes. And then CVVHDF, we put the two together, dialysis and convection together. So we have both dialysis solution and replacement fluid. And we're removing fluid and solutes. And the only thing I want to add is removing both small and large solutes with the two combined. All right, so let's take another look at our patient here and see what kind of therapy that she might need. So here, patient length of stay is 3 days. Creatinine is 1.3. Just to drive home, when you look at that independent number, we don't know what that means, right? Let's assume the patient came in and their baseline creatinine is 0.4, right? This is greater than 200% over. This patient is in a lot of problems. If it's a bodybuilder, they might have a normal creatinine of like 1.1 or something like that, right? Below their muscle mass. But BUN's clearly elevated at 78, probably developing some elements of uremia. Potassium is even now more elevated, 6.3. But blood cell counts are very high, 40,000. It's like an abscess or C. diff or something like that. Intake is about 1.5 liters. Outtake in the last intake in the last 6 hours, 1.8. Output in the last 48 hours is still only 1.35 mLs. They had no urine output in the last 6 hours. Remember, failure is going to be anuria for that 12-hour period, so they're quite a ways there. They're ventilated. They have a MAP of 63. They're on norepinephrine, dopamine. Now we added some vasopressin, and now their urine output is even less. It's 0.2. For the failure rifle criteria is going to be less than 0.3. So now it's lower now. So now they are in failure. So let's talk about CRRT dosing for you to have an idea of how we, at least on the MD side, how we write our prescriptions, and that'll help you maybe understand a little more. So according to the KDIGO guidelines, they suggest delivering an effluent volume of 20 to 25 mLs per kilo per hour for CRRT in acute kidney injury. And this is listed as 1A. And the second point here is it says this usually will require a higher prescription of effluent volume. So when we think of effluent volume rates, that pre-filter, post-filter, the amount of effluent that we're giving coming out. When we say here 20 to 25, there's often a discrepancy between what we prescribe and what the actual dose that the patient gets. And so very commonly, actually, what we write for intentionally is a higher amount. We write for about 35 mLs per kilo per hour, because the higher prescription, we think then that the patient will get a closer dose to what we want them to get. And we're actually going to go over some of the calculations in just a second here. All right, so what is our CRRT dose, right? So it's mLs per kilo per hour. So we have our effluent, which is our dialysate, our replacement fluid, and then the patient net ultrafiltration divided by the patient weight. So here, in this particular example, we have dialysate of 1,000, replacement fluid of 1,000, our post patient net ultrafiltration 200, and then the patient's weight. So we add up all three of these on top here, 2,200 mLs per hour. We divide by the weight, and here the particular prescribed dose is 31.4. I don't often get this particular, and use the calculation. We often just have like a table that just has 35 mLs per hour, and we just go by that, and that's usually, and we often tend to over-prescribe a little more just to guarantee that the patient actually gets the prescribed dose, because that's important. But if you were going to be very particular, this is how you do it. Key points here. So the best evidence to date supports a minimum dosing of 20 to 25 mLs per kilo per hour in all modalities of CRRT. As I mentioned, and to reiterate again, it's usually necessary to increase the prescription to ensure the prescribed dose is delivered. So frequent assessment of actual delivered dose is recommended just to make sure the patient's getting that minimum of 20 to 25 mLs. And then when we look at determining a prescription of renal replacement therapy, it is mandatory to consider patient parameters other than small solute clearance, such as the patient's fluid balance. We actually want to give them fluid, keep them even, take fluid off, their acid base and electrolyte homeostasis. Very often, again, they're going to be acidotic, so we're going to make sure they get more bicarb. Very often in CRRT, we can't give them enough bicarb, and so we'll run additional bicarb outside of the patient and then just take that fluid off, which CRRT is so good at taking the fluid off. And then look at their nutritional status. Nutritional status, why this is written here is because remember that with convection, you're losing some of those larger molecules. And some of those molecules are proteins, like the cytokines that I mentioned. And so someone could have they do have higher nutritional needs, higher protein needs when they're on CRRT, just because they're going to lose some of those proteins through the convection process. All right, so anticoagulation, we're almost there. You guys are hanging in there and you're going strong. So really, like, to reiterate again, one of the reasons why maybe we're not having the best outcomes, we look at all research, et cetera, on CRRT is because people aren't on CRRT long enough. And one of the biggest problems is the filter clogging. And when we look at the filter clogging, there's really two things that we have control over. One is going to be the blood flow rate, which is why I emphasize we use the higher, larger French size catheters so we can have that quicker blood flow rate. The other thing that we can do is we can thin the blood, so we can use anticoagulation. So this is important because, again, when the filter goes down, you lose time on therapy, and then less clotting just means the fewer filter changes. Ideally, really, a standard should be that that filter should last, I'd like to see them at least 2 days before they go down. That really should be like the standard of what we should be trying for. I know the filters last 72 hours and we change them, but as a minimum, we'd like to see them, I would say 1 day maybe, but we're not always achieving that, as you know. So it is recommended for patients to have anticoagulation. And commonly what we use is heparin. Very easy to use, so I won't read through this whole thing. But it's not reflex, right? Very often if we're running high enough and fast enough blood flow rates, we find that maybe we don't need anticoagulation. We might try without. Or there might be a contraindication, right? We might be dealing with a patient who's in renal failure but with a recent head bleed. We're not going to want to anticoagulate. Granted, what we talk about our anticoagulation is for the filter, not for the patient, but some of the anticoagulation does go to the patient. And so in very sensitive patients like head bleeds, we're not going to want to do that. So we use heparin. And I talked about instances where maybe we wouldn't want to use this, such as GI bleeds, head bleeds, etc. But also we want to talk about heparin-induced thrombocytopenia, so HIT. And then what happens maybe if someone has HIT. So if they have HIT, those are the antibodies that are formed because of heparin binds to what's called platelet factor 4, and you develop antibodies to that. And then you have an increased risk of those platelets then aggregating, causing thrombotic disease. And then when you have that, the filter is going to clog really fast, right? Because that's going to be all that absorption on the filter, and you're going to have that increased transmembrane pressure really quick. So you can't use heparin in those particular instances. So other options are going to use are going to be considerations for citrate. And that's like a little bit outside the scope because we don't use it that much. Another option, which is what I use at other sites, is argatroban. So you can just, same thing as we're just having that little heparin syringe, right, go into the filter. You can have argatroban instead, and then avoid what does very often become much more complicated with the citrate. That's it. Hopefully that was reasonable to review how it works. Any particular questions?